Welcome to Shamim Institute of Medical Sciences, SIMS MedPrep. I am Dr. Kamran. So we are starting the endocrinology. This is our first lecture of endocrinology. So first of all, we will study the thyroid development in our first lecture of the which is endocrinology series. Okay. So we will discuss about what is the development of thyroid, how thyroid is developed. Okay. To start with thyroid development, you must know what is the primitive structure that makes a thyroid. And that primitive structure is called primitive pharynx. Primitive pharynx that the diverticulum is made, which is called thyroid diverticulum in initial phases. Okay, when there is a 24 to 28th day, and there is 24 to 28th day, the structure is produced, which is called thyroid diverticulum. How? I will tell you in the picture. If you can see in the picture, this picture, okay, there is a structure which is produced at week 5. This is a structure at week 5, which is embryo at week 5. There is creation of some pouches. Okay, there is creation of some pouches, and also there are the ridges, and also there are some arches. Okay, so a pouch is endodermal portion, which is inside. Like you can see, these are the pouches. Okay, so in between the first and second, the structure which is produced, which is thyroid diverticulum here. In the middle, between the two sides pouches, in between the two side of pouches, like this side and this side, in the center, the structure is produced, that is thyroid diverticulum. Okay, so it is produced from the base of pharynx, base of the pharynx. Okay, remember, so you can see this is the base of the pharynx. So structure of thyroid starts from a thyroid diverticulum, and that thyroid diverticulum is present in embryologically structure between the pouches. Okay, so if I will go more deep, so it is present between the copula and tuberculum impar. Okay, what are these? This is not important to remember, but you should know that there is a copula structure. Copula structure is here, and tubular imporum, this structure is here. So between these two, there is a structure that is thyroid diverticulum. This blue is thyroid diverticulum. Okay, so this is from the base of the pharynx. So you should know the embryology of the thyroid. Okay, next we will go. Thyroid diverticulum arises from floor of primitive pharynx and descends into the neck. It is connected to the tongue by a thyroglossal duct cyst. It's a very important point. Why it is starts from the base of pharynx and connected to the tongue with a duct, that is thyroglossal duct. Very important. And which is normally disappears. Very important one, but it persists as a cyst or in the form of pyramidal lobe of thyroid. So there are two complications that can produce from thyroglossal duct cyst, that is thyroglossal duct that can present as a cyst, and they can present as a pyramidal lobe of thyroid. Okay, let me show you in a picture. So you can see this picture, a thyroid migration, which is normally when there is a thyroid that is produced, it normally go in normal location, and normal location is this. Okay, in the neck, Okay, so when there is a creation of thyroid in the base of, this is normal place, that's called base of the pharynx. So it will go. It is called migration. Okay, I am highlighting with the blue color. This is a migration which go into the neck. From the base of the pharynx, it will go into the neck, interior neck. That is normal location. Okay, so sometime it's not go. Okay, it's retained. It is present in the base of the pharynx that present as a cyst form, that is thyroglossal duct cyst. So you can see in this diagram, this is thyroglossal duct cyst. Okay, and it presented as a anterior neck mass. That clear? Now we will study thyroglossal duct cyst. Okay, thyroglossal duct cyst. Thyroglossal duct cyst is presented as anterior midline neck mass that moves with swallowing and protrusion of the tongue. Is that clear? Is that clear? So how you will differentiate a thyroglossal duct cyst with a persistent cervical sinus, which is leading to pharyngeal cleft cyst? Very important point. I will tell you the difference between the thyroglossal duct cyst versus versus very important, that is the pharyngeal cleft cyst. Okay. First of all, the one difference will be in thyroglossal duct cyst. This is midline. Very important point. This will be in the scenario like this. The patient has a swelling in the anterior of the neck, super high yield midline position. When they will give you the scenario, there is a swelling. This is swelling on the lateral of the neck, lateral of the neck. So this is the pharyngeal cleft cyst. Next important point to differentiate is that, very important point is that they will give you the history. When there is protrusion of tongue, when there is a swelling, when there is protrusion and there is swelling that moves, very important. Swelling moves, okay, with the swelling or protrusion of tongue. But this is not happening in the pharyngeal cleft. These are two very important points to differentiate thyroglossodopsis and pharyngeal clefts. Is that clear? So you can see in this picture, this is a classic thyroglossal duct cyst. Okay, thyroglossal duct cyst. This is thyroglossal duct, and this is anterior neck mass. Next, we will go to discuss about ectopic thyroid tissue. Ectopic thyroid tissue is any tissue that is outside of normal place. And the most common important question that they ask, that is, which is a site which is most common that present as ectopic thyroid, that is lingual thyroid. And very important, its removal may leads to the hypothyroidism, and it is the only thyroid. Sometimes it is present in a few cases. And they will give you the scenario. They will give you a scenario like this. A patient came to you who has any infection, and patient was now has developed his growth. Okay, and now he is 14-year age, 12-year age, and he has developed some growth maturity. And the symptoms starts. What symptom starts? Hypothyroid symptom. Okay, so it's mean when their patient who is having a symptom after the growth, after the 12-year, 4th year, and that exacerbation have happened after the infection. It's mean his thyroid has come abnormal place, that is not competing, that is not producing the enough thyroid hormone to compete the metabolic demand. So when infection, when there is growth, we need more thyroid. So when in lingual thyroid patients, there will be not complete demand will be fulfilled. So that's the symptoms happens after infections, after adolescence, after other like crisis. Is that clear? So what are the other sites that can the ectopically thyroid tissue develop? Most common is lingual, we have discussed. What are the other sites? Okay, see this picture. Okay, this is most common lingual. Okay, this is a lingual thyroid. Next, it can be the sublingual. This is also ectopic thyroid. Next is prelaryngeal thyroid. And fourth is on the path of this thyroglossal duct. It can happen in any site. Is that clear? Next, we have discussed about what is thyroid diverticulum. Okay, we have discussed about what is the different like positions. We have discussed about difference between thyroglossal duct cyst and pharyngeal cleft cyst. Now we will discuss a few more points. Thyroid follicular cells are derived from endoderm. Okay, so this is also a sometime asked. Thyroid follicular are derived from endoderm. There is endoderm, ectoderm, mesoderm. We'll study in detail in other chapters. So you should know it is from the endoderm. Parafollicular cells also present that arises from the fourth pharyngeal pouch. We will study the pouch in reproductive system. Just you should know that somehow what are the pouches, what are the arches, what are the ridges, what are the clefts. Just you know some basic concept in detail. We will study in the reproductive system. Parafollicular cells are from the fourth pharyngeal pouches. Okay. Next, you should know this structure. What is the structure? First of all, this is a left subclavian and this is brachiocephalic. In front of the this is a trachea, and then in there is a thyroid here. Very important super high yield question that asked in exam is the blood supply. Okay. Blood supply of thyroid is superior thyroid artery and inferior thyroid artery. Superior thyroid is coming from external carotid and inferior thyroid coming from thyrocervical trunk, which is a branch of subclavian artery. I will repeat the super high yield exams question. MCQs for exam. Number one is the what branch blood supply of the thyroid, which is the superior and inferior thyroid. Okay, what is superior thyroid is branch of which artery? Superior thyroid is branch of external carotid. Okay, and what inferior thyroid is branch of? Inferior thyroid is branch of thyrocervical trunk, and thyrocervical trunk is from the left subclavian artery. Okay, is that clear? So you see in this picture the left subclavian, which gives the thyrocervical. Thyrocervical gives the inferior thyroid, and from the if we see the superior, so it is branch of the external carotid. Is that clear? So we have discussed the blood supply of the thyroid. Is that clear? Next, we will discuss now a very important concept, that is foramen cecum. If you see the tongue, let's suppose this is a tongue, and in the tongue there is a midline ridge like this. Okay, so this is, for example, posterior side, and this is anterior side of the tongue. In posterior side, there is area like this. The posterior of this median sulcus, it is called median sulcus of the tongue. Okay, the posterior of median sulcus of the tongue is it is the adult variants of foramen cecum. So you can see this is a posterior of the tongue. This is the connection between the thyroid. So okay, this is the connection. Okay, the thyroglossal duct that is generated abnormally when persists, so it's connected with foramen cecum. Okay, that is the posterior most of the tongue. This is foramen cecum. This is the thyroglossal duct. If it is not disappeared, it lead to thyroglossal duct cyst or some midline, which is pyramidal lobe of thyroid. Pyramidal lobe of thyroid. Okay, so two complication can happen. Either it make the cyst here, this can produce the cyst, and they can also produce some extra thyroid here. This is pyramidal lobe of the thyroid. Okay, next. Next, we will discuss the pituitary gland. Okay, so what are the basics of pituitary gland? How the hormones are produced? We will discuss now the detail of pituitary gland. Okay, so we will discuss anterior pituitary and posterior pituitary. Anterior pituitary and posterior. Anterior pituitary releases the follicular stimulating hormone, luteinizing hormone, adrenocorticotropic hormone, thyroid stimulating hormone, prolactin, growth hormone, beta endorphin. And very important is melanotropin, MSH, which is secreted from the intermediate lobe of the pituitary. Actually, there is anterior and posterior, but no division of intermediate. There is a space that is present, but we cannot consider is actually a lobe, but it is a portion that also secretes some melanotropin, that is melanocyte stimulating hormone, MSH. Super high yield, number one important question. So, okay, from the next, when I will say super high yield and important question, it's the question that is usually asked in exams, most of the exams. Okay, so first question they will ask from this topic is, what is the derivative structure of anterior pituitary? Oral ectoderm, Rathke pouch. Okay, so oral ectoderm, Rathke. What is anterior pituitary derived from Rathke pouch? Oral ectoderm. Is that clear? And they will ask you the next question in our exam. So there are many cancers from the anterior pituitary. So they derive from specifically Rathke pouch. Okay, Rathke pouch. Okay, so next we will discuss the subunits. There in all the anterior pituitary and most of the anterior pituitary hormone, they are divided into a subunits. One is alpha and next is the beta. Okay, alpha is the same, that have same characteristics in all hormones. Alpha is the same. It is same in all, but beta is very specific for every hormone. It determines the hormone specificity. Okay, is that clear? For example, beta HCG. You have heard the word beta HCG. Okay, so we check in pregnancy. Why pregnancy causes hyperthyroid after pregnancy? They give you history of hyperthyroid. Why? Reason is that beta HCG have same alpha subunit as the TSH. So when hyperthyroid symptom in pregnancy happen is due to the thyroid stimulating hormone activity. Okay, no, it is actually the alpha subunit of beta HCG hormone. So that causes the hyperthyroid symptoms. Okay, because beta subunit is a different in beta HCG and TSH. So that's why beta HCG has a different domain. It has a different function. Okay, next we will discuss what is the pro-opiomelanocortin. Pro-opiomelanocortin. Okay, when there is the uh, in there is a degradation and making of a protein on genetic level, when there is a gene effect, the gene will change the protein structure and the protein is made because all hormones are protein. Remember, All hormones are protein. When the protein is generated inside cell, they are mildly degraded, or some portion are removed from protein to make it functional. To make the hormone, we have some modification in the cell level. Is that clear? So when there is a production of ACTH, adrenocorticotropic hormone, this is super high yield exams question also. When there is a modification of ACTH, what happens? The structure is developing. When ACTH is made, in ACTH, this ACTH, adrenocorticotropic hormone, the structure is produced, which is a primary initial structure, pro-opiomelanocortin. That after degradation, they divide it into different units. For example, this structure will divide the different unit. One, they will give the pure ACTH, and they will release also the MSH, and they will release the beta endorphin. Okay, beta endorphin. So three structure made from pro-opiomelanocortin. So that's the reason when there is a feedback response, when there is a decrease cortisol in our body, a feedback response will come to anterior pituitary, and anterior pituitary will start to create ACTH. Okay, and ACTH when created, it starts from a product pro-opiomelanocortin. And when the ACTH is produced, always remember it's always create MSH and beta endorphin at the same time. So in summary, when there is creation of ACTH, they will always produce the MSH and beta endorphin at same time. Okay, the processing of ACTH is also creating MSH and beta endorphin. This is a summary of our topic. Next, we will discuss about what is acidophilic cells and what are basophilic cells. Actually, it is the histopathology and when we staining method. Okay, when we check, there are some cells that are basophilic. So these are the follicular stimulating hormone, luteinizing hormone, ACTH, thyroid stimulating. Okay, and acidophilic, these are the prolactin and growth hormone. Prolactin and growth hormone. Remember, all are the basics mostly, but a few exceptional acidophilic are the growth hormone and prolactin hormone. Okay, next we will discuss about posterior pituitary gland. Posterior pituitary, it is called neurohypophysis. Anterior is called adeno and posterior is called neuro. Okay, it stores and release vasopressin. We have discussed in detail in our MRCP lecture series because I have also taught the endocrinology section of MRCP. So I am repeating again here if that student who has taken that lecture of MRCP, that is most important high yield question is that there is a storage that happens in posterior pituitary. Production of antidiuretic hormone happens in the hypothalamus. Super high yield, I repeat here, when the question asks where where the ADH where the ADH and the oxytocin produced, what produced? The answer is hypothalamus. Hypothalamus. When they will say where they are stored, when they use the word stored, so answer will be posterior pituitary. Posterior pituitary. So remember, okay, produced in hypothalamus and stored in posterior pituitary. ADH and oxytocin, they are not produced in posterior pituitary. Next important question: which carries these hormones? A carrier protein. Super high yield question also. Next, who carry this from hypothalamus to this is the carrier proteins. That carrier proteins, one of that carrier protein is neurophysin. Neurophysin. Neurophysin is carrier protein that carry from hypothalamus to the posterior pituitary, and this is derived from neuroectoderm. Remember, anterior is derived from oral ectoderm, and this is derived from the neuroectoderm. Next, we will discuss the structure of adrenal cortex and medulla. Adrenal cortex and medulla. There are two divisions of adrenal gland. Adrenal gland, which is present on the surface of the kidney, above surface of kidney. First, you should know the basic anatomy in your mind. It is kidney, and above surface there is a gland, that is adrenal gland. And gland has a further division into two. One is cortex and one is the medulla. Okay. Now we will discuss about the different subdivisions of the cortex. First of all, you should know this is adrenal gland. Adrenal gland is divided first of all in upper side, which is yellow, is the capsule. Yellow is the capsule. This is capsule. And next inside the capsule, we have three division. One is zona glomerulosa, which is a zone that is presenting as a glomeruli. Glomeruli is present in kidney. So that have a similar structure like glomerular, that is called glomeruli, like glomerulosa. Zone that is resembling glomeruli is zona glomerulosa. Next is zona fasciculata. They are presenting as a fascicles. And the third is reticularis, presenting as a reticular formation. So that's so-called zona reticularis. Is that clear? So how to remember it one by one? GFR. GFR is from the kidney. Okay, just GFR tells us the function of kidney. So remember, if there is a kidney gland which is above the kidney is adrenal, the zone or GFR, glomerulosa fasciculata reticularis. Now we will discuss one by one. Zona glomerulosa. Okay, how how it is regulated, what it produces. Okay, what it produces and how it is regulated. We'll discuss one by one. Zona glomerulosa is producing the salt hormones. Why I'm using the word salt? Minerals, mineralocorticoid. Okay. So when I use the word salt, minerals, this means it is mineralocorticoid. So it is mineralocorticoid that is produced by the zona glomerulosa. How it is regulated? It is regulated by the sympathetic endings. I use the word sympathetic endings. Sympathetic ending, because sympathetic ending produces the catecholamines. Okay. Is that, sorry, it's not sympathetic ending. Sympathetic ending is produced by the chromaffin cells. It is produced, regulated by angiotensin. Okay, I repeat here, it is produced by the, it is it is regulated by the angiotensin, angiotensin 2. Actually, also this is also angiotensin released from sympathetic system, but it's not from the nerve endings. Okay, also it is controlled, regulated by sympathetic activity. Of course, when there is sympathetic activity, there is also release of catecholamine from the nerve endings and angiotensin 2 release also, because it also causes the vasoconstriction of the vessels, arterioles, and as well as is act on the cortex, which is zona glomerulosa, and promotes the mineralocorticoid release. And the primary hormone that produced in zona glomerulosa, which is primary mineralocorticoid, is aldosterone. Next, zona fasciculata. Zona fasciculata is producing primarily glucocorticoid. Okay, it's producing glucocorticoid. So you should know the first, which is primary hormone, glucocorticoid. Okay. Now, primary hormone class is glucocorticoid, and which is a basic one, foremost primary hormone is cortisol. How it is regulated? It is regulated by the ACTH from anterior pituitary and corticotropin releasing hormone from hypothalamus. We will study in the next slide how these hormones are regulated. First of all, we will discuss about anterior pituitary ACTH, that is controlling to release of glucocorticoid, and CRH, corticotropin releasing hormone. Corticotropin releasing hormone. Okay. This is from hypothalamus. So there is a chain of events. Hypothalamus release CRH, act on the anterior pituitary, and pituitary will release ACTH act on the adrenal gland, on the zona fasciculata. It will release glucocorticoid. Glucocorticoid will go into the, and they will release cortisol. Set clear, the primary glucocorticoid is cortisol. So this is a zona fasciculata. Next, zona reticularis. Zona reticularis is producing the first hormone class, androgens hormone, reproductive hormone. Okay, remember, it is reproductive. Next, most important is dihydroepiandrosterone. Okay, that is primary hormone that is produced in this zona reticularis. What is this? DHEA, dihydroepiandrosterone. How it is regulated? Same as zona fasciculata. It is controlled by the ACTH and CRH. Next is the medulla. Medulla is controlled by nerve ending. Super high yield question here. It is controlled by the nerve ending. Because in nerve ending, there is a release preganglionic sympathetic fibers are present that are controlling, and that preganglionic sympathetic fiber release the catecholamines, and catecholamine increase epinephrine and norepinephrine. Okay, so this is happening in stress response. This, they give the stress when there is a stress on our body. Epinephrine, norepinephrine releases. How? Because the nerve ending preganglionic synthetic fiber in chromaffin cells of medulla, which is part of the adrenal gland, releases these system. Is that clear? Next, we'll discuss about the endocrine pancreas. Pancreas is endocrine gland also. It's producing the glucagon, it's producing the insulin, and third is somatostatin. We know the insulin released from beta cells. We know the glucagon released from alpha cells. But there is a third, that is delta cell. That is interspersed between alpha and beta cell, and that is releasing somatostatin. Okay, we know that alpha is from peripheral cell that is releasing glucagon. Beta is releasing the insulin, and third very important is the delta, which is somatostatin releasing cells. Is that clear? So you can see in this is alpha, this is beta, and interspersed between them is the delta. This green color. Okay, next we will discuss and the few of the concepts. Okay, so normal gland, and on the left side you can see the histology that is sometimes asked in USMLE step 1. You should know this is the picture exact histology. So first of all, in the upper layer you can see there are globules. These are called fat globules. Fat, because adrenal gland has the fat also. The fat layer on the side of the capsule, there is a fat layer. These are fat globules. So there is, when there is histology coming in USMLE step 1, the upper layer is fat. So this is not the start. Start is from here. So you can see an upper zone, which I am highlighting with this blue color, this zone. So you are thinking this is most likely with a glomeruli. Okay, this structure resembling growth. So this is zona glomerulosa. And next I am highlighting with a brown color. So this is zona fasciculata. So okay, these are fascicles. And there is a zona reticularis. So you can see by the green color, this is zona reticularis. And the fourth with a black color, that is medulla. This is medulla. This is medulla. Okay, this is the zona reticularis. Okay, this is the zona fasciculata, and this is the zona glomerulus. Okay, see on this diagram on the right side, angiotensin 2 controlling the zona glomerulosa, ACTH controlling fasciculata, ACTH controlling the zona reticularis. Is that clear? So first they will ask you sometime in a different way. Which of the following zone is controlling blood volume? Then you will think, how? How is possible? What is this? What is this type of question? Yes, sometime like this, think about blood volume. Oh, yes, I remember. Blood volume is controlled by aldosterone. Aldosterone is released by the zona glomerulosa. So remember, blood volume controlled by zona glomerulosa. And they will ask you which of the following is controlling the glucose metabolism, which of the following is controlling vascular tone, which of the following is controlling the libido, which of the following is controlling the sex hormone, which of the following is controlling the fertility. So you should know that which zone is producing hormone and what will be the effect. We'll discuss in detail in our next lecture, but you should somehow what is the vascular tone, then blood glucose controlled by the ACTH cortisol. Due to this cortisol increases the not only the tone but increases the glucose. It causes the glucose resistance, is benefit resistance also. And androgen are released by zona reticularis, which causes improves the libido and protect hair in the woman. So you should remember which hormone is released and how its action is the on the different zones. So next we will study different type of the hypothalamic pituitary hormones. First of all, ADH, antidiuretic hormone. Released from the, I repeat here, released from the, it is released from ADH and oxytocin, released from the hypothalamus, produced from the hypothalamus, stored in the anti posterior pituitary. Okay. So what is the action of ADH, antidiuretic hormone? Increases water permeability of distal convoluted tubules and collecting ducts in kidney to increase the water retention. So it is a easy. I will go with a little bit in a fast speed. So it is easy. If any question, if any discrepancy, so you can just text me. Okay. Okay, next important, alcohol consumption decreases ADH. So I have discussed in detail with a practice question in MRCP lecture, but it's not needed in USMLE step 1 in other. So ADH is suppressed by the alcohol. Okay, and there are some drugs that increases the ADH, that's carbamazepine, SSRIs. There are other drugs also that increases, but not important at your level. You should know the function. What is function? Permeability increase of the water in distal convoluted tubules, and it increases water absorption. That's it, and increases blood volume. If there is a deficiency of ADH, then there will be a polyuria and dehydration. We'll study in detail when we will study the dehydration or deficiency and the excess problems. Next is CRS, corticotropin releasing hormone. Corticotropin releasing hormone is from the hypothalamus. Okay, produced from hypo. I will write the word hypo, and this is hypothalamus. So they are produced from hypothalamus. It increases ACTH from anterior pituitary. It increases MSH from the anterior pituitary. I told you when there is increased ACTH, also this will be increased and this will be increased. We will study in Cushing syndrome. So why there is pigmentation? When there is excess ACTH, this is the reason. When there is excess ACTH, is also producing MSH, and this causes pigmentation, melanocytes deposition. Studying in detail in the Cushing syndrome. Next, dopamine, very important hormone, super high yield, that is from the hypothalamus. Hypothalamus. This is called also prolactin inhibiting factor. It is antagonist of prolactin, released from hypothalamus, decreases prolactin from anterior pituitary. Super high yield, it is antagonist of prolactin. Also, super high yield question is also inhibiting the TSH, thyroid stimulating hormone from anterior pituitary. So it inhibits the prolactin and inhibits TSH. Most of students don't know about this. So you should know this is also inhibiting TSH. Next, growth hormone releasing hormone. Okay. There is also relation of these drugs, which is dopamine antagonist, which are antipsychotics. We will study in detail. We will study the prolactin regulation and dopamine regulation. Antipsychotics actually are dopamine antagonists. So when we give the antipsychotics, remember, antipsychotic when given, it inhibit the infundibular pathway, which is actually a inhibitory pathway, which inhibit prolactin release from anterior pituitary. When we give antipsychotics, what happens? It inhibit the dopamine. And there is no dopamine, there will be excess prolactin and excess TSH. So that's the reason antipsychotics causes the hyperprolactinemia and galacturia because of dopamine antagonistic effect. This is the reason of why antipsychotic causing hyperprolactinemia and galacturia by inhibition of dopamine, because that dopamine was necessary to inhibit prolactin. So excess prolactin, excess galacturia. Growth hormone releasing hormone next. It is released from hypothalamus. It increases growth hormone from the anterior pituitary. What is this? Simple, we will study in detail in the next slides. Analog. Analog of this is casomorelin, which is used in HIV lipodystrophy. HIV lipodystrophy. Can anybody tell which drug in HIV causes lipodystrophy? It is just a simple question. It's not necessary. So we have the many drugs in HIV that are used, and some of the drug causes the lipodystrophy. And interesting thing is that HIV causes lipodystrophy, and the drugs that are given that also contribute the lipodystrophy. So that's the reason we use this drug, because a HIV patient will be thin, lean, metabolism will be very, so there will be a weight loss and other problems. So growth hormone is given to growth hormone releasing hormone, and log of growth hormone releasing hormone is the casomorelin. So next is growth gonadotropin releasing hormone. Gonadotropin is releasing the FSH. They are suppressed by hyperprolactinemia. Remember, when there is prolactin, prolactin is inhibiting gonadotropin. So when there is hyperprolactinemia due to increased prolactin release from anterior pituitary, this prolactin is inhibiting this prolactin. When there is a release of prolactin, prolactin will inhibit this gonadotropin. So whenever there is a prolactin, when there is postpartum period, okay. So when there is a postpartum, which is hyperprolactinemia, postpartum, postpartum, there is increased prolactin that is causing the milk production, that is causing other regulations. So that condition decreases gonadotropin and decrease FSH. So remember, so that's the reason there are many theories that say that when there is decreased FSH during the postpartum period, there is some irritability, tension, anxiety, and there are other psychiatric problems. There's a postpartum psychosis, postpartum anxiety, postpartum depressions because of decreased estradiol, decreased estrogen. There are theories which are having a new guideline. They are saying that estrogen decreased release of LHFSH postpartum period due to hyperprolactinemia. There's very important role in the regulation of psychiatric problem like postpartum psychosis, postpartum delirium, postpartum depression. This is very important and new researches are going on. This is a overview I am telling you how the hyperprolactinemia is important because it suppresses gonadotropin. The gonadotropin analogs. There are two control of gonadotropin. One is tonic control and next is the pulsatile control. Gonadotropin releasing hormone, which is leuprolide, okay, which is if this is given in a tonic form, tonic mean a tone, okay, like continuously you can say, okay, it is given continuously. So it suppresses hypothalamic pituitary gonadal axis when it given continuously in a one tone, tonic. So remember one tone continuously. This is causing the antagonistic suppresses hypothalamic pituitary gonadal axis. When it is given in pulse style, okay, given a small dose, high dose, and then slow, high dose and slow in a pulse form. Okay, like this, I will draw here. So when it is given in a pulse like this, and slow, and then high and slow, and then high and slow, it acts as agonist. Agonist. Very important super high yield exam question we study in reproductive section. Okay, in reproductive, when there is infertility, when there is infertility in women and there is a libido decrease in the men, we give this pulsatile GnRH At the exam question, they ask you which of the following gonadotropin releasing hormone you will give. So there will be two options: tonic, GnRH, and pulsatile. So for the infertility, for the decreased libido, we will give in a pulsatile manner, because in pulsatile manner it act as a agonist. But when we give tonic, so we will give in the many diseases, like when there is excess of the FSH and LH, okay, due to some problem. We'll study and reproductive section. Leuprolide is a expressing hypothalamus. It prevents gonadotropin releasing hormone. Next is MSH, melanocyte stimulating hormone. Melanocyte stimulating hormone increases melanogenesis, production of pigmentation, melanocytes. It causes hyperpigmentation in the Cushing disease, because MSH and ACTH share the same precursor molecule, which is pro-opiomelanocortin. I have told you already this concept. Okay, is that clear? Next, we will study the oxytocin. Oxytocin, it causes uterine contraction during the labor, and very important in the milk let-down reflex. Very important, because when there is a suckling, there is a release of the milk. So there is also modulation. The researchers say that oxytocin is happy hormone. Oxytocin is happy hormone. Okay, when I will say the word energetic hormones, active hormones, happy hormones, so there is a two or three hormones that are most important: epinephrine, norepinephrine, okay, dopamine, and oxytocin. These four hormones are very important for our controlling our energy, our mental state, our social bonding, our feelings, okay, our behavioral responses. These are regulated by these four very important hormones. Norepinephrine, one of them is, and then dopamine. Third is the oxytocin. So norepinephrine, sometime there is epinephrine, but not important. Norepinephrine, dopamine, oxytocin, these three are very important. And one of them, oxytocin specifically, very important for social bonding. Okay, very important for social bonding. Mood changes, depression changes also happen due to deficiency of norepinephrine and dopamine. Okay, when there is a decreased social bonding, it must be the oxytocin deficiency, because oxytocin is very important for the social bonding. Okay, your social quotient is also directly proportional to the oxytocin. Okay, it's not a generalized, but it is like a from this concept. So because it modulates fear, anxiety, social bonding, and mood and depression. Next, prolactin, we have discussed prolactin inhibit gonadotropin and it's stimulate lactogenesis. When there is pituitary prolactinoma, it causes amenorrhea, osteoporosis, hypogonadism, and plaque. Of course, we will study why pituitary prolactinoma causes amenorrhea, decreased libido. Okay, this is the reason, because it inhibits gonadotropin, decrease FSH, and decrease LH causes the hypogonadism. And very important point is the delayed postpartum ovulation. Breastfeeding is causing the what is delayed postpartum ovulation? Remember, start from breastfeeding. When there is a breastfeeding, there is increased prolactin. And there is breastfeeding, increased prolactin. Increased prolactin in breastfeeding causes decreased gonadotropin. Decreased gonadotropin causes the delayed postpartum ovulation. Natural contraception. That is also a very important question. Which is natural contraception? Which is natural contraception? Breastfeeding. Okay, so breastfeeding is natural contraception. You should know. Somatostatin, statin stops. Remember this word. Statin stops. So whenever you heard the word somatostatin, it stops all the hormone. It stops all secretion. We will study in gastrointestinal system also. Somatostatin stops all secretion. In endocrine, it also decreases the growth hormone and TSH. Growth hormone and TSH, they are inhibited, decreased, and it is called growth hormone inhibiting hormone. We'll study more for somatostatin in the gastrointestinal also, because this is very important. So it is always inhibitory in either it is gastrointestinal system or endocrine system. Next, we will study the thyrotropin releasing hormone, TRH, thyrotropin releasing hormone. Okay. Thyrotropin releasing hormone. How it is released from hypothalamus. Remember, this is from hypothalamus. It is released from hypothalamus, and it increases the TSH from anterior pituitary and prolactin from the anterior pituitary. This is a super high yield exam question. Super high yield. Okay. Okay, we understand it must increase the thyroid stimulating hormone, but it also increases prolactin. So I will tell you this concept. Whenever there is a hypothyroid patient, okay, hypothyroid causes hyperprolactinemia. Remember always, okay, hyper hypothyroid thyroidism causes hyperprolactinemia. How? And hyperprolactinemia causes inhibition of gonadotropin. So that's the reason in hypothyroidism, many females cannot have the conception. Okay, you must know the logic. Why hypothyroidism is why TH, TSH, why T3, why T4 check in pregnancy? When there is infertility in the females, why we check T3, T4, TSH? What is the relation? Yes, this is the relation. Because hypothyroidism increases the prolactin. Prolactin inhibits the gonadotropin releasing hormone. Gonadotropin decreased, then FSH-LH is decreased. Then FSH-LH is decreased, then estrogen is decreased. Other hormones are decreased that are necessary for conceive, that are necessary for regulation of the reproductive system. Is that clear? So I will repeat here. Hypothyroidism, either it is primary or secondary, that increases the that increases the that increases thyrotropin releasing hormone. And this thyrotropin releasing hormone causes more thyroid stimulating hormone, more prolactin. Is that clear? Okay, I repeat, super high yield question, very relatable. It is very interesting. Start from a patient presented with hypothyroid symptoms. And a female who is saying, I'm not able to conceive for many months and I am very like feeling a dizziness, fatigue. I cannot have energy. I have a constipation. Sometimes I feel my heart is not like beating. Okay. And there is some my hair problems. Is that clear? So these are symptoms of hypothyroidism presented to you. What should be your evaluation in this patient? First of all, I am sitting in the clinic. I am doing some question or some. I will explore hypothyroidism because of the symptoms, and my differential will go the is infertility cause. My differential will go to find the reason. I will check prolactin. I will first check T3, T4, TSH. If diagnosed it is hypothyroid, I will go to check prolactin. Because in hypothyroid, prolactin is high. Why? I will tell you know the logic. Start from here. I will show you in a this diagram. Understand from this diagram. Okay. First of all, there is a decreased T3, T4, hypothyroid. So feedback response will go in hypothalamus. That feedback response will be to increase thyrotropin releasing hormone. Is that clear? If there is thyrotropin releasing hormone is increased, that was initiated by the hypothyroidism. This is number one step. There was hypothyroidism. Number two, the hypothalamus will increase thyrotropin releasing. Thyrotropin releasing hormone also increases the prolactin. Also increases the prolactin. Okay, I am pointing out this third point, which is increased prolactin. Now go for the fourth point. When there is increased prolactin, now I will mention with the red color. A fourth point, when this is increased prolactin, you follow my line of red color. This will go and this will inhibit this gonadotropin releasing hormone. When there is inhibition of gonadotropin releasing hormone, there will be no LH and no FSH released from the anterior pituitary. And no LH and no FSH. So we know that this LHN and FSH, they causing increased estradiol. They are increasing the estradiol and progesterone that are hormones that are necessary for regulation and conceiving a baby. Okay. So ultimately, what happened? The consequence happened that there is no estradiol and no progesterone. That's the reason hypothyroidism causes infertility. Cannot. This woman cannot conceive. Is that clear? Now you understand my logic and concept. Follow this third point. Very important. Third point is very important when there is the inhibition. Okay, inhibition. Why? Inhibition of gonadotropin, there is prolactin. Prolactin excess we have discussed is causing inhibition of gonadotropin. Gonadotropin, when inhibition happening, LH and FSH not produced. And LH, FSH not produced, they did not go inside the reproductive organs. It cannot increase the testosterone and the progesterone. and the not increase estradiol and the progesterone. So that cannot regulate the system and it leads to the infertility. I think it is very clear now. Okay, so this was very important concepts, very high yield question. Okay, growth hormone, which is called somatotropin. Okay, it is also called somatotropin. It is secreted by anterior pituitary. We have discussed this. Now we will discuss what are the factors that increases the growth hormone and what are the factors that decreases growth hormone. First, we will discuss that increases growth hormone. These are sleep, is hypoglycemia, stress response, and puberty and exercise. So these are the factors that increase the growth hormone. Growth hormone increased by stress, hypoglycemia, puberty, exercise. What are the factors that decreases this? These are the factors that decrease aging, obesity, and hyperglycemia. Okay, what is the regulation? It is regulated by the growth hormone releasing hormone. Growth hormone releasing hormone is coming from hypothalamus, and this growth hormone releasing hormone will come from hypothalamus. This is from the hypothalamus. And this will go and like this is an act on anterior pituitary. And this growth hormone releasing hormone will increases growth hormone. Growth hormone has action on different organ systems. Growth hormone is very important for the linear growth as well as the muscles growth. First of all, we will study one by one. Growth hormone action number one is happening on the liver, and it's regulate and produce a very important regulatory molecule that is insulin growth factor 1. This is called insulin growth factor 1. This insulin growth factor 1 is super high yield and very important because this acts on a different organs. One of them is the bone, and next is the muscle. Okay, insulin like growth factor number 1 act on bone and muscle. In the bone, it increases amino acids, protein synthesis, DNA, RNA synthesis, chondroitin sulfate, glycose, amino gland, collagen deposition, cell size, and cell number. Very, very important. All growth factors that are needed are increased under influence of insulin growth factor 1, which is also called somatomedin. 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 Okay. Somatomedin. It increases the all amino acid, protein, DNA, chondroitin sulfate, glycogen, cell size, cell number. Also increases amino acid uptake and protein synthesis inside the muscles. Next, growth hormone has direct effect on the not. There are different effects. One is direct effect of growth hormone, and other is via effect via the insulin growth factor 1. So on the bone and the muscle, the growth hormone is acting via the growth hormone factor, which is IGF-1. But growth hormone has a direct effect. I am writing the direct on this, which is lipid cells. It causes the decrease uptake in the peripheral adipocytes. Okay, it acts on adipocytes, so it decreases glucose uptake, increases lipolysis, and super high yield, very important point. So that's the reason growth hormone causes insulin resistance. Okay, I will tell you here the MCQs. Okay, growth hormone causes the insulin resistance and increases the hyperglycemia, and it increases the risk of diabetes mellitus. Why? It is simple, very simple. Why? Reason is that when there is decreased glucose uptake, when there is decreased glucose uptake, okay, so there will be more glucose inside blood because peripheral tissue who are accepting the glucose that are decreasing the glucose from blood, which are inhibited by the growth hormone. So it's mean there will be hyperglycemia. Okay, so that is very good. So it is diabetogenic. Diabetogenic. Remember the word diabetogenic. Is that clear? So this is release in very important concept. Now we will discuss release. The release of growth hormone is happen in pulses, pulse form. Okay, it is from the pulses. Is that clear? That is growth hormone releasing hormone, and that growth hormone releasing hormone is super high yield, is more in the night time. So this is more in the night time. Okay. So this regulation, which is a pulsatile regulation, is more GHRH release at the night time. So most likely the night time is very important. Is that clear? Okay. Okay. So it is Very important, super high yield. Next question, which is not written in the. I have made a some logic. Okay. Have you noted your brother, your sister, and your family member who are not doctor, who are not engaged in high tension level activities? They are like doctor, engineer. If your brother who is just present at home and doing some the daily business and other activities, they will be higher in the height as compared to you. Most of the families have this problem. Like me, I am a doctor. I have a less height as compared to my younger brother. Okay, so you have thought about in major of the families, one person who is who is older, but it is less in height, but a one person who is a who is younger, but it is has greater height. Why? The logic is growth hormone. Logic is growth hormone. Why? Because growth hormone also increases in response to the stress. But very important point is that here I will differentiate the logic of this growth hormone is more released when there is more activity. Super high yield. Okay. Growth hormone is released when there is more activity. More activity, more interaction, more going inside and out, and more activation of your basal metabolism. Okay. So the growth hormone, most likely the others like our brother or sisters, when they having a more activities and super high yield athletic activity, they are involved in athletes, like they have gaming, like cricket. If any athlete activities, running, okay, badminton, whatever. So these type of people who have history of daily activities, history of going inside the sun bathing, who have a any physique like a 30 or 40-minute activity, that increases the growth hormone, that increases the height. So we all the doctor, all the engineers are having a limited activities. We usually not. I am asking. I am not telling all of the people. A major of these are busy doctors and students. They are engaged in daily reading and studying activities. They are not likely doing the exercises. Okay. Of course, stress causes increased growth, but it's not like actually causing that type of stress. Stress is not like in a medical student stress. Stress is a different stress. Okay. So it's not the stress like we have in our medical field. Okay? Stress is infection stress. Stress is body stress. Okay? It's not anxiety. Is that clear? So stress is a different concept. We stress have in our medical field, that is a difference. Okay. So in summary, when there is activity, when there is more athletic activity, when there is a more daily, so that leads to more growth hormone, more height. Okay, next. It is just general observation, and I have some read some articles. I have find a few articles who favor this concept. Of course, I am not telling you by this. There are some articles that saying that this is a logic because of when athletes have why athletes have more muscle mass, why athletes have the uh, more growth on the like these you can say many of the muscles who have a more growth. Why? The reason is that muscle growth is under influence of insulin growth factor 1. Okay, insulin growth factor 1. Insulin growth factor is released by growth hormone. So that is also a very logical concept. Okay, next is secretion is decreased by aging, obesity, hyperglycemia, somatostatin, and next is excess of growth hormone is the which is pituitary adenoma. We will study in detail. It can lead to the acromegaly and gigantism. Acromegaly is use of word in adults and gigantism use of word in children. And the treatment of these is the somatostatin analog. We will study in detail in our next lectures. Okay, is that clear? So today we have studied our what is thyroid gland, what is the anatomy of thyroid gland. We have studied today what is the difference between thyroglossal duct cyst and branchial cleft cyst. We discussed branchial cleft cyst is present on lateral side and thyroglottal duct cyst is present on anterior midline structure. When there is a history protrusion of the tongue and swallowing, there is a mass that is moves that is classically thyroglossal duct cyst. Okay, and there is more infection chance when there is branchial collapses. When there is a history of infection, history of fever, history of increased C-reactive protein, always think about branchial collapses because it is more easily to infect branchial collapses. Next, we have discussed the blood supply of the thyroid that is superior. and inferior. Superior is branch of the external carotid. Inferior is branch of the inferior is the branch of the thyrocervical, and thyrocervical is branch of the subclavian. Is that clear? Next, we discuss the different type of hormones, different type of ADH and prolactin and ACTH and MSH, and we discuss the other very different domains of in their functions and regulations. And we discuss about the cortex and medulla. We have discussed the cortex. There are three zona of glomerulosa, fasciculator, reticularis. We discuss about the primary hormone in glomerulosa is aldosterone. In fasciculator, the primary hormone is cortisol. In reticularis, the primary is androgen hormone, dihydroepiandrosterone, and medulla is producing the epinephrine and norepinephrine. Then we have discussed the growth hormone, which is increase when there is stress, puberty, exercise, hypoglycemia, decrease when aging and obesity and hyperglycemia. Then we discuss about when there is how it's regulated growth hormone. Releasing hormone is releasing hypothalamus, increasing growth hormone increasing insulin growth factor 1 from the liver. Insulin growth factor 1 has bone effect and muscle effect. Bone effect all increase. Muscle effect all increase. Amino acid intake, protein synthesis. But very super high yield important question we discuss about the growth hormone that is causing insulin resistance and it is diabetogenic. Why? Because it decreases glucose uptake by the adipocytes. That was the most important question we discussed about like this. And then we discuss about what are the factors. Some interesting concepts we have discussed why some of the athletes, some of the like men, some of the women who have more height as compared to normal pairs. This was a logic because more athletic activity, more engagement in our daily activities leads to more release of growth hormone and more release of the insulin growth factor 1 that causes more growth of his muscles and more growth of the bone. So last we discuss about the excess of growth hormone happening to pituitary adenoma that is called acromegaly in adults and gigantism in children, and the excess growth hormone treatment is octreotide, which is analog of somatostatin. We discuss somatostatin that stops growth hormone and all the other. Okay, thank you so much for the lecture. Take care.